All right, welcome MBBS students to this explainer. Today, we're diving into a true masterclass on the adrenal glands. We aren't just memorizing diseases here. We're looking closely at the surgeon's stepwise approach to decoding some of the most fascinating and honestly sometimes perilous conditions in the human body. The adrenal gland might be small, but let me tell you, the pathologies here pack a massive punch. Here's our clinical roadmap for today. We'll start with anatomy and physiology, move into the incidentaloma algorithm, look at cortical pathologies, tackle phaeochromocytomas, and finally wrap up with surgical emergencies. Let's get right into it. So, starting with section 1, adrenal anatomy and physiology. Now, what's really interesting about this layout is how it dictates our surgical approach. You can't understand the pathology without appreciating this normal baseline state. The adrenal gland isn't just a simple block of tissue, it's a remarkably potent hormone factory. Notice the right gland's incredibly dangerous proximity to the inferior vena cava. As a surgeon, that short right adrenal vein draining straight into the IVC, well, it demands your absolute respect. Over on the left, you've got the gland intimately hugging the pancreatic tail and the spleen. Knowing these anatomical relations is absolutely crucial for anticipating complications in the OR. Okay, consider this your ultimate clinical cheat sheet. You really have to conceptualize the adrenal gland as two completely distinct organs wrapped into one package. The outer cortex, which comes from the mesoderm, has strict zones, the glomerulosa for aldosterone, fasciculata for cortisol, and reticulatus for androgens. The classic memory trick here is GFR stands for salt, sugar, sex. But then in stark contrast, you have the inner medulla. This comes from neural crest cells and basically acts as a neurological outpost, just pumping out catecholamines like adrenaline and noradrenaline. It's a dual nature setup, and you've got to keep that straight. Moving on to section 2, the adrenal incidentaloma algorithm. Nowadays, with high-resolution abdominal scanning being done for everything from trauma to kidney stones, you're going to see this all the time. It's arguably the most common adrenal dilemma for a modern clinician, a mass found completely by accident. By definition, an incidentaloma is an asymptomatic adrenal mass found on imaging that was explicitly done for something else. Now sure, the vast majority turn out to be completely benign, non-functioning adenomas, but you absolutely cannot just brush them off. We have to be methodical. We have to systematically rule out two major threats here, malignancy and functional hormonal activity. And that brings us to the exact algorithm every surgeon has to follow. Remember the golden rule of endocrine surgery? Biochemical testing comes first, imaging comes second. So step 1, is it malignant? We figure this out by assessing tissue density on a non-contrast CT. Step 2, is it functionally active? We run targeted biochemical tests, like a 1 milligram overnight dexameth suppression test or checking plasma metanephrines. Then, step 3, is surgery actually indicated? As a rule of thumb, we recommend excision if that tumor is larger than 40 millimeters, or obviously if it's secreting excess hormones. Actually, I really want to reinforce a high-yield clinical pearl right here. On that non-contrast CT scan we just mentioned, benign lipid-rich tumors usually have a low density of 10 Hounsfield units or less. This specific number, 10 HU, is literally your best friend in the clinic. Why? Because it definitively saves your patient from unnecessary surgery. And honestly, it saves you from a massive headache by giving you the confidence to just do safe, watchful radiological waiting. Next up is section 3, surgical pathologies of the cortex. So we're shifting gears from those asymptomatic incidental findings to the clinically active, profoundly dangerous stuff. Think of this as a mini grand rounds visual review. You've got the classic textbook physical signs of Cushing syndrome, the central obesity, that really fragile skin, severe bruising. And right next to it, the gross surgical specimen shows you exactly why this is happening. Massive, asymmetrical, bilateral adrenal hyperplasia. As a clinician, you really need to visually connect what you see on the outside of the patient directly to the underlying hyperplastic pathology that's driving all that toxic cortisol excess. So the crucial point here is that you must be able to distinguish between these two completely different types of cortical hormone overloads. With Conn syndrome, you have an autonomous aldosterone-producing tumor. That means high aldosterone, suppressed renin, and your classic hypokalemia. But with Cushing syndrome, it's a cortisol-producing lesion. So you get high cortisol, profoundly suppressed ACTH, and severe metabolic signs. It's those unique biochemical signatures that will completely dictate your diagnostic pathway and your eventual surgical approach. Take a close look at this classic canary-colored tumor. This sliced surgical specimen is a golden yellow aldosterone-producing adenoma, which is the absolute hallmark of primary hyperaldosteronism or Conn syndrome. What's absolutely incredible for you as future surgeons to realize is that doing a minimally invasive laparoscopic adrenalectomy to take out this little adenoma can essentially cure a patient's lifelong, highly drug-resistant hypertension. Honestly, it's one of those truly triumphant surgical victories. But of course, not all cortical masses are small and benign. This imaging shows an adrenocortical carcinoma. Just look at the massive, heterogeneous, really necrotic appearance of it. Unlike those small adenomas, ACC is fiercely aggressive. If you're investigating an indeterminate tumor and it's over 6 centimeters, that automatically demands an open, radical surgical resection, no exceptions. Laparoscopic approaches are strictly contraindicated here because the risk of breaching the capsule and spilling tumor cells is just completely unacceptable. And I need to deliver a pretty sobering statistic to underline exactly why we take these larger masses so seriously. 13%. That is the dismal 5-year survival rate for stage 4 adrenocortical carcinoma when it presents with distant metastases. That terrifying number is exactly why early detection of incidentalomas, incredibly thorough biochemical investigation, and achieving pristine R0 surgical margins, meaning literally zero microscopic tumor left behind, are absolutely paramount. All right, section 4, medullary tumors, specifically the phaeochromocytoma. We are now leaving the kind of slow-burning metabolic world of the cortex and diving into a highly volatile clinical environment. I want you to consider this carefully. What actually happens when the body's primary fight-or-flight center forms a tumor? What happens when a mass just autonomously dumps massive, uncontrolled surges of adrenaline and noradrenaline straight into the bloodstream? Well, the cardiovascular consequences are extreme. Patients present with terrifying paroxysmal hypertension, blinding headaches, rapid palpitations, and just profuse sweating. Because of that immense volatility, I need to drill in an absolute professor's pearl for your pre-operative management. You must always, and I mean absolutely always, block alpha receptors first, using a drug like phenoxybenzamine. Only after the patient is fully, completely alpha blocked can you even think about introducing beta blockers to control the tachycardia. If you block beta receptors first, you leave all that alpha-mediated vasoconstriction completely unopposed. If you do that, you risk inducing a lethal hypertensive crisis right there on the ward. Don't do it. And this brilliantly illustrates what we're up against. Notice the characteristic central necrosis on this scan of a large phaeochromocytoma. These tumors are incredibly vascular, they're fragile, and they are so metabolically hyperactive. Just physically handling them during surgery can cause massive, instantaneous catecholamine surges. That right there is exactly why that meticulous preoperative medical blockade we just talked about is absolutely non-negotiable. This visual really highlights the immense technical challenge you'll face in the OR. You're seeing a paraganglioma, which is essentially an extra-adrenal phaeochromocytoma, being delicately extracted from a really treacherous position anterior to the abdominal aorta and right alongside the inferior vena cava. When you're operating in a space this tight on a tumor that can cause wild, life-threatening blood pressure swings just from you touching it, it requires extreme surgical precision, and it requires flawless, absolute hemodynamic control from your anesthesia team. Finally, Section 5, Surgical Emergencies and Conclusion. Okay, we've talked a lot about planned operations and methodical algorithms, but now we have to cover the life-or-death scenarios. These demand immediate, reflexive recognition from you as a clinician. Analyze this scan. You are looking at a massive left retroperitoneal hematoma secondary to an acute adrenal hemorrhage. Because the adrenal glands are among the most highly vascular organs in the human body per gram of tissue, things like blunt trauma, severe bacterial sepsis, or even excessive anticoagulant use can precipitate catastrophic uncontained bleeding. And while we often manage it conservatively, you have to be vigilant because it can rapidly lead to profound hypovolemic shock. But perhaps even more deceptive and honestly more terrifying is acute adrenal insufficiency, or an Addisonian crisis. I'm warning you right now, this crisis is rapidly fatal if you miss it. These patients present with profound shock that is completely out of proportion to whatever apparent illness they have, and it frequently mimics a surgical acute abdomen. You literally cannot wait. This demands immediate aggressive action. You push copious IV saline and a 100 milligram bolus of IV hydrocortisone before your diagnostic biochemical tests even come back from the lab. You act first, confirm later. To wrap up this explainer, I want to leave you with a core philosophical framework directly from Bailey and Love that perfectly encapsulates all of endocrine surgery. Confirm the diagnosis with biochemical tests, render the patient safe, consider localization, decide if surgery is indicated, choose the operative approach. It's a brilliant summary. I challenge you to confidently apply this exact stepwise logic to every complex patient you see in your future clinical practice. The algorithms are right here in front of you. But when the pressure spikes and seconds count in the trauma bay, the real question is, will you be ready to make the call?